Good morning and welcome to the 12th lecture in our series, Healthy Aging. My name is Jim McBain. I'm a volunteer with the Osher Lifelong Learning Institute, and I have the pleasure of moderating today's lecture. Up front, I'd like to recognize the planning committee and the programs that help make the Healthy Aging series possible. These are the U of M Geriatric Department, Turner's Senior Wellness Program, Osher Lifelong Learning Institute, Silver Club Memory Programs, Turner African American Services Council, Institute of Healthcare Policy and Innovation, and the National Poll on Aging. Thank you all. Our topic today is firearm safety among older adults, and it's with Dr. Patrick Carter. I'll introduce Dr. Carter in more detail in just a minute. But before I get to that, I'd like to say a few words about the Zoom webinar platform. Just a few words. We're all familiar with it by now. And the main thing for you to know about is the Q&A button. If you have a question for our speaker, just click on the Q&A icon and type your question into the box, and we'll get to it at the end of the lecture. We also have a closed caption option available, so if you wish to see the speaker's words stream across your screen, you can do that as well. If you have any technical difficulties, the first thing you should do is just exit the application and come back in again, and you can find the address for coming back in the email that invited you to this lecture. I'd also like to call your attention to the next lecture in this series. On Friday, April 1st at 10 a.m., our lecture will be The Phases and Faces of Dementia. Please mark it on your calendars. Now to today's lecture. First, the legal disclaimer. The views expressed during the lecture and the Q&A do not necessarily reflect those of the University of Michigan. Now my pleasure to introduce our speaker. Dr. Patrick Carter, MD, is an Associate Professor of Emergency Medicine, School of Medicine, and Health Behavior and Health Education, School of Public Health at the University of Michigan. He is the co-director of the U of M Institute for Firearm Injury Prevention, the director of the CDC-funded University of Michigan Injury Prevention Center, and part of the leadership team for the NICHD-funded Firearm Safety Among Children and Teens, or FACTS, consortium. Dr. Carter's research is within the field of firearm injury prevention, specifically the development, testing, and implementation of emergency department-based interventions to decrease firearm violence, youth violence, and associated risk behaviors, such as substance use among high-risk urban populations. He's the current chair of the ACEP Trauma and Injury Prevention section, serves as an assistant editor for the Annals of Emergency Medicine, and has served as a member of the technical advisory group focused on developing a firearm research agenda for the American College of Emergency Physicians. Dr. Carter has research funding from a number of federal agencies, all focused within the field of violence and injury prevention. Dr. Carter, I now turn it over to you.
Thank you so much, Jim, and thank you to the Healthy Aging series and all the partnerships that made this possible. I'm going to share my screen here. And hopefully everyone can see that.
You look good. It looks good.
Okay, great. Thank you for that warm introduction. I'm going to talk today about firearm safety among older adults. Just to highlight kind of the general objectives of the talk, I'm going to talk a little bit about the problem of firearm injury in the United States and talk a little bit about how we think about in sort of the research world and clinical world to develop solutions and to reduce injury and what we know currently about what works. And then I'm going to finish by talking a little bit about the new institute that's been established here at the University of Michigan and kind of the work that we do to think about how to develop some solutions for this problem moving forward. And we'll end with some questions, hopefully. Okay, so I usually start talks like this by just sort of outlining first what we mean when we say firearm injuries. So people come to this issue and come to this topic with a lot of preconceived notions about what we're talking about. And I usually want to level set a little bit at the beginning so that we're all on the same page. And when I talk about firearm injuries, I'm thinking about everything from a child who finds an unsecured firearm to youth violence that escalates to lethal violence, to school shootings, to police violence, to intimate partner violence, to older adult firearm suicide. And today we'll be focusing a little bit more on firearm injuries that pertain to older adults. But when I talk largely about firearm injuries, we're talking about all of these different types of problems. And sometimes we'll think about solutions that can address across these different topic areas, but sometimes we have to tailor and think about these solutions really focused on the specific topic at hand. I also like to point out that firearms can be a controversial issue. However, we really try to focus on what are the common goals around firearm injuries and recognize that everyone brings diverse perspectives to this topic area. But our focus is really on what does the science tell us about how to decrease injury and death occurring by firearms. And I think when we focus on that as the key focus, we can really think collaboratively around how we solve this problem. And it's imperative that folks who own firearms, who use them legally, who enjoy having them for hunting and target shooting and for protection, are part of the solution to the problem of firearm injury. My thinking about this is it's similar to any other public health issue or public health disease that we face. We've long thought about how we decrease people from smoking. We know that it causes lung cancer and emphysema and a whole host of other problems. We think about how we can keep kids safe when they're in cars by building better car seats. We think about how we train new drivers. We think about child-proofing medications so that kids can't inadvertently get into them and end up with drug poisonings. Firearms are no different than any of these other issues. There are evidence-based scientific solutions to the problem that we can develop by studying it in rigorous ways, the same as we have for all of these other issues across the past years. And I like this quote from David Satcher because I think it frames nicely in a single sentence why we think about it this way. If it's not a health issue, why are people dying from firearms? And people are dying. So approximately 40,000 Americans die every year from firearms. That's about 60% of those are suicide deaths. Almost 40% are due to homicide. And we've seen a steady increase in the number of firearm deaths that are occurring every year. And you can see on the screen here, it's the red line is the depiction of firearm deaths occurring since back to the late 1990s. And you can see in the year 2017, for the first time in over a generation, firearm deaths in the United States actually surpassed motor vehicle crash deaths. And that's some due to the fact that firearm deaths have been increasing during that time, and also some due to the fact that we've had a lot of success at decreasing motor vehicle crash deaths. And I'm going to talk a little bit about that parallel again later. The problem of active shooter incidents or mass shootings has also been increasing, although a small part of the overall problem of firearm deaths. They're significantly horrific events that occur, and they have been occurring in both increasing numbers over the past decade, as well as an increased number of fatalities per incident. But the types of firearm injuries that we see really differs among different populations. And so while we can talk about the totality of the numbers, we also need to think about which populations are affected by which problems. And you can see here, just based on age occurring across the lifespan, different firearm injuries are different problems. The purple line is sort of the total number of firearm fatalities that are occurring at different ages. And you can see there's really two big peaks. There's the peak that occurs that starts in early adolescence and peaks in the early adulthood time period. And that's largely driven by firearm homicide and an increasing rate of firearm suicide. And then a peak that occurs again among older adults over the age of 65. And that peak is largely driven by firearm suicide. And so when we think about the problem of firearm deaths among older adults, we really need to also think about that a large number of these deaths are occurring because of firearm suicides, and how do we address that problem? I also just want to point out a couple other things. In general, amongst all of these ages, males die at a higher rate than females from firearm injuries. However, it's important to recognize that among female deaths, a large number are due to intimate partner homicide, and that is a part of the homicide problem, especially in that young adulthood period, and even increasing among older adults. So specifically, when we think about older adults and firearm deaths, older adults over the age of 50 represent about a third of all firearm deaths that occur every year in the United States. And as I said in the last slide, the majority of those deaths, almost 82%, are due to suicide, and about 16% are due to homicide. Now, both firearm suicide and homicide rates have been increasing among older adults over the past decade, not as high a rate as we've seen among the youth population, but still have been increasing slightly during that time. And among all suicides that occur among older adults, firearms are the most common mechanism, responsible for about a little over 2/3, or about 75% of suicide deaths. When we look at firearm deaths as a whole across the United States, there are significant disparities by race and ethnicity. The biggest disparity we see is for Black Americans, where the homicide rate for Black Americans is actually 6 times that of any other group. When we look specifically for suicide, we see that the suicide rates are disproportionately higher among white and Native American, Alaskan Native populations. And all of this is to say that it's important to consider the structural factors that drive a lot of these underlying disparities. So we know that, for example, redlining, systemic racism, and persistent economic disinvestment in our urban centers has led to these higher rates of homicides. And in our rural communities, we see the higher rates of economic distress, poverty, decreased access to mental health are really driving a lot of the findings we see for suicide, especially among white Americans and Native American Alaskan Natives. And so it's important to think about what are those structural factors that we can address at the sort of community and society level that are driving a lot of those elevated rates of firearm deaths. And here you can see that that overall, when you think about rural versus urban versus suburban communities, firearm deaths in the United States actually occur in all of these types of communities. It's not any one specific community that's afflicted by this problem, but that the types of injuries that we see among different types of communities are different. So in our urban centers, as I just said, we see a higher rate of homicides. And then in our rural communities, we see a higher rate of suicide and unintentional firearm injuries. And so it's important to consider the types of injuries we're seeing in those settings, but also acknowledge the fact that firearm injuries occur across all of our communities and really are a problem among urban, suburban, and rural communities as a whole. So all of the data that I've sort of showed you so far and talked about is really focused on firearm fatalities. And I can tell you a lot less about the number of firearm injuries that don't cause an immediate death in this country. And that's because the data we have isn't very good. And I won't get into all the specifics of that, but what we know about the data is we think that about 70,000 deaths 70,000 injuries occur every year that end up in the emergency department with firearm injuries. And largely those are assault type injuries or interpersonal violence. And that's because the suicide injuries that we see actually don't make it to the emergency department because there's such a high fatality rate among that population. But this data, one of the key goals of the type of research that I do and researchers around the country that are focused on firearm injuries is to improve the quality of this data so that we have an understanding of how many people are showing up to our emergency departments every year. And this is a key goal with the CDC data that we see. So what's the role of firearms and firearm access in causing these firearm injuries? And we know that a homicide of a household member is 3 times more likely in a home where there's a firearm access, so where somebody can access a firearm. And that's especially true when we look at the problem of intimate partner homicide. So women are 5 times more likely to be murdered by their intimate partner when the partner has access to a firearm. And in nearly 75% of school shootings that occur across the United States, a firearm was acquired from the student's home or the home of a family member or relative. And when we start to talk a little bit later in the talk about what are some of the things and reasons why we talk about safe locked storage and other ways of increasing safety. It's because children visit homes, and when they visit homes, they have access to firearms that are not secured safely. We also know that firearm access in a home increases suicide risk, even after we adjust in our analyses for prior psychiatric diagnosis, and that risk is about 5 times as high. So when we think about what's the role of firearms in the home in terms of as a risk factor for injury, it's really firearm access, and I'll talk a lot about this and come back to this, but it's firearm access by high-risk individuals during high-risk time periods. And that's the single biggest modifiable risk factor for firearm injury. And so when I think about how we approach this problem as a solution, it's about decreasing that access during that high-risk time period by that high-risk individual. And those are the types of things that we think about in terms of solutions. So how does older adult firearm suicide and homicide differ from what we see among other populations? Well, for firearm suicide, we know that among older adults and elderly populations, we have fewer warnings. Attempts are more likely to be planned. They're less likely to be impulsive the way they are among adolescents and young adults. These older adults are more likely to have suffered from a prior diagnosis of depression. And the risk factors that we see are very different. So we see issues around prolonged physical illness and functional impairment, increasing depression risk, and then increasing suicidal ideation. Social isolation and loneliness, especially as they may lose a partner or spouse in the home. An increased number of stressful life events around financial troubles or family discord, and decreased social support, family members moving away and not having a close-knit community around them. And so those are a number of the risk factors that we see for firearm suicide among older adult populations that we may not see as much among younger adults. And so we have to think about that role of those things in our solutions. For interpersonal violence, among younger adults and adolescents, we see a lot of the firearm violence that is occurring in the community or in the street. But among older adults, what we see is that violence tends to occur more in the home and with people that they know when compared to younger adults, and more likely to be due to issues of intimate partner violence or elder abuse. We know that dementia is both a risk factor for suicide and homicide, and that can be even early in the disease before we see a lot of cognitive decline among the patient. And especially when dementia progresses to later stages where patients may have agitation, they may be experiencing paranoia, we start to see more aggression. And when that occurs in the setting of an unsecured firearm, there's an increased risk of both suicide and violence. And so that's when we start to when we think about those solutions, we start to think about what are the things that we can do, and we start to see evidence of cognitive decline in older adults, and how do we address that, especially when there's a firearm in the home that may be accessed, again, by a higher risk individual during that higher risk time period. So what does ownership of firearms look like in the United States? Well, about 265 million firearms exist in the United States. That's an estimate. And that's about 23% of the US population that owns firearms, split roughly evenly between handguns and long guns. But what we're seeing most recently is a shift in the percentage of the population that owns. So we're seeing the percentage of the US population that owns firearms go down, but that they're owning a greater number of firearms. And as I talk about firearm ownership specifically among older adults, we can see that largely they own multiple guns. And here's that data actually right here. So how many older adults own firearms? Well, over a quarter of adults between the ages of 50 and 85 report that they own firearms. That percentage doesn't significantly decrease as they get older. Another 10% report that they live in homes where somebody else owns a firearm. And as I said just in the last slide, almost 3/4 own multiple firearms with an average of about 3. When we think about the types of firearms, about 40% own only handguns, about 18% own long guns only, and then almost half own both handguns and long guns. So a mix of different types of firearms. And then when we think about who among the older adult population reports that they own firearms, people are more likely to be male, they're more likely to be white, they're more likely to have been a prior active military service member. They're more likely to have children that visit or live in the household. They're more likely to be from higher income households. They're more likely to be in rural settings than suburban settings and urban settings. And they're more likely to live either in the western half of the United States, in the South, or then sometimes in the Midwest. And so we can see that as we start to think about where we have to address the problem, this helps us to sort of think about who owns firearms and who's potentially at highest risk. And that, again, coincides with what we're seeing in the data around firearm suicides, which we're seeing this really high rate of firearm suicides, especially among older white, rural, male men. So when we talk to older adults about why they own firearms, so largely older adults tell us that they own firearms for protection. A smaller number own for target shooting or hunting or because they inherited the firearm. But about 70% say the primary reason for owning a firearm is to protect themselves. And that protection is really because they are concerned about the possibility of strangers or potential criminal invasion, and less specifically because they are concerned that somebody they know specifically is after them. But despite saying they own primarily for protection, largely they also say that they live in safe neighborhoods and they feel safe in their neighborhoods and don't feel like they're going to be attacked. So when we think about how we address the problem, we have to acknowledge that there is a significant fear amongst the population of people who own guns, and that's primarily a driver for why they own guns and why they may not store them in secure ways. And so we have to think about, as we talk about safe storage and lock storage, what are ways that we can enhance that while all still offering them the opportunity for the protection, which is the primary reason that they're owning a gun. Folks who don't own guns tell us largely they don't want them or don't need them, or that they feel that they're dangerous and they don't want them around in their families. We know that there's also been a shift over the past decade to 2 decades in the types of guns that people own. So we've seen a steady increase in domestic US firearm production since the early 1990s. But the type of guns that we're seeing produced are actually more likely to be in the pistol and the rifle family than revolvers and shotguns. And that has implications for the types of injuries that we see occurring among patients who show up to emergency departments and who end up dying from firearm injuries. And I'll talk a little bit about that here in a sec. So you can see that here's an example of taking that same data, but breaking it down now by the caliber of pistols. And what we're seeing for calibers of pistols is that we're seeing larger numbers of large caliber pistols being produced by US gun manufacturers. And that has implications, obviously, for the type of injuries that we're seeing and a decline in the smaller caliber pistols. We're also seeing similar types of findings in the crime data, so the types of guns that are recovered from violent crime events. So it's both in the types of guns that are manufactured, but also in the type of guns that we recover from crimes. We're seeing these larger caliber pistols and less smaller caliber pistols. So what does that mean? Well, this is a graph looking at the severity of the types of injuries that we see come in from firearms among trauma patients. And you can see year over year since the early 1990s, we've seen a steady increase in the severity of the types of injuries that we're seeing among these types of patients. And so this change or shift in the caliber of the pistols that are being produced and that are being recovered from crimes and from suicides are having an impact on the types of injuries that we're seeing. So we're seeing more of these higher severity injuries, and that's occurring among all populations, but especially among older adult populations over the age of 45. And that's regardless of sex or whether the injury is due to firearm suicide or homicide. And so the severities of the types of injuries are definitely increasing. Oops. Sorry, I think we had, there we go. Here's another example of what we're seeing. This is data from a single trauma center, where you can see at the red line is the increase in the larger severity caliber gunshot wounds, and this is as a percentage, and a decline with the blue line of the smaller caliber type injuries, and the medium caliber firearms are the orange line, which are roughly flat. So we're definitely seeing this change in the types of injuries that we're seeing. Sorry, my slides are, here we go. Okay, so I've talked a lot about the fatal firearm injuries we're seeing. We've talked a little bit about the types of non-fatal injuries. We talked a little bit about how that pertains specifically to older adults. So what does all this mean in terms of cost to the US economy? And the economic cost of firearm injuries is somewhere around, and this data is actually a little bit old at this point, so it's probably higher than this, but somewhere around $229 billion a year. And that's both in direct costs for providing acute medical treatment for patients who suffer from a firearm injury, but also from lost work and productivity when somebody dies or is injured, lost quality of life, paying for criminal justice proceedings and jail time when this is an intimate partner violence event or a homicide event. And so that cost ranked roughly against these other issues that we have in society falls squarely in between the cost to the system of obesity and how much we spend on Medicaid every year and how much we spend to address the problem of smoking. And so it's really, it's a significant problem to the US economy in total. So I'm going to shift gears. I've talked a little bit about sort of what the problem looks like, but I'm going to shift a little bit to how we think about developing solutions and addressing this problem, and try and give you some of a sense of how this pertains specifically to older adults and the types of things we can do to decrease the types of injuries and patterns of injuries we're seeing among older adult populations. So first, I tell you at the outset, we think about this as a public health problem. So we think about the public health cycle or the scientific method to solving this problem. We try and define the problem, and a lot of the data I've given you hopefully has helped to define what the problem looks like, especially among older adult populations. But then we try to think about what are some of those risk and protective factors. And I talked about some of those for firearm suicide and for firearm homicide. We're thinking about social isolation and economic distress and access to a firearm for older adult suicide, thinking about elder abuse and intimate partner homicide when we think about firearm homicide among older adult populations. And that leads us to think about how we construct prevention strategies to address the problem. And then once we figure out if those strategies work, then we can think about implementing them broadly amongst the community, and then monitoring their effectiveness and tweaking them as they need to. The other way to think about that is taking data and generating knowledge from that data that can inform specific actions to decrease firearm injuries. I think it's important as we think about these types of solutions to not just think about any one type of solution. I'm going to mention some different things that cross sort of these different areas. So things that we can do individually, one-on-one with a patient, for example, in an exam room, as we talk to them about their ownership of firearms and how to keep them safer, to things we can do in the community, to things we can do at the policy level. And I think a lot of people come to think about firearms as there's only one type of solution. Either it's got to be policy-based or it's got to be something in the exam room. But I think about all of these different types of solutions or approaches as being one part of a larger puzzle for how we solve this problem. And it's not any one individual thing, it's all of these things and solutions at all of these different places. And I think the parallel here is to motor vehicle crash injury. And I'll just detour a minute from firearms and tell you, you saw in the initial slide there, I showed you that firearm injuries had surpassed motor vehicle crash injuries in the United States in 2017 for really the first time in a generation. And that's largely due to not addressing the problem of firearm injuries, but actually addressing the problem of motor vehicle crash injuries at a really high level, using all of these methods I talked about, the scientific method, the public health model, understanding the problem, thinking about risk and protective factors, and developing solutions. And I can just tell you this picture you're seeing here, which is a car crash from the 1950s, would not occur today. And it would not occur because we've built better cars. We've changed driver behavior around alcohol and drug use when driving and distracted driving. We've changed the way we build roads. We would never build a road this close to a pole today. And we've actually changed the way that we've responded to car crashes to get there quicker with good EMS services and get patients to the hospital where they can get the care they need. And so as we think about that, we've approached this from all these different angles, policy and behavioral angles and engineering solutions and educational solutions and building better environments around cars. And And here's just a schematic about sort of the collection, and this isn't even everything, this is all I could fit on the slide, but it's thinking about how we've decreased over the past 50 years, starting really with Ralph Nader bringing up unsafe at any speed and the issues around cars and the safety issues around cars in the early 1950s to today in the mid 2000s. And all of the things we've done to increase the ability of cars to be safer for occupants, and all of the safety devices, seat belts and airbags and collapsible steering columns and better road lights for nighttime driving and lane departure warning systems, but also behavioral modifications. We've really changed the norms in this country around alcohol impaired driving. And we've developed policy solutions that included limits on how intoxicated you can be in driving. And we have minimal drinking age laws for folks who are under the age of 21. We've developed, and as I said in the last picture, better roads, and we have divided roadways, and we have better signage, and we have better streetlights, and we have put all these systems into place. We've also focused on specific populations that are high risk. For example, among teens, we've really focused on how do we train them to be better drivers. We know that a high rate of car crashes occur in that first 6 months that they're learning to drive. And we've developed graduated driver licensing laws that allow us to do a staged approach to teaching them to drive so that they're safer and that decreases injury outcomes. Among older adults and elderly populations, we really think about when is the right time to have a patient stop driving. Are they still capable of driving? And we're going to talk a little bit about that as we get to guns, around how we think about that for firearms too. So just to give you sort of the framework for how we often think about this in the world of injury, we think about what's called the Hayden Matrix. This was developed by William Haddon, who really is a father of injury epidemiology. He was the first head of the National Highway Traffic Safety Administration. And he developed this idea of the Hayden Matrix, which really broadened the idea of injury prevention from just the car and the driver to thinking about all of the factors that surround them. So the driver and the driver behavior, the vehicle that they're in, the physical environment around them, the social environment around them, and really thinking about all those things that occur prior to the crash, at the time of the crash, and after the crash. And then thinking about what are all of the countermeasures that we can develop to help make this event not happen. And we can do the same type of approach, this sort of Hayden Matrix approach, this injury prevention approach, to all of the issues around firearm suicide among older adults, thinking about access to mental health services, thinking about how we address issues of loneliness and social isolation as adults get older, to thinking about how firearms are stored and how we reevaluate whether older adults who might be developing issues of cognitive decline, when is it the right time to not have them have firearms, to thinking about how we get better access to systems of prevention and suicide hotlines and mental health supports and screening algorithms to identify the things that occur at the time of the injury around ammunition and these larger caliber pistols versus smaller caliber pistols, to smart gun technology. And we're going to talk about some of these different things, but we can take that same approach, that same scientific approach to addressing all of the aspects of the issue to the problem of firearms. So I'm going to talk here for a minute about a couple of really key things that I think are important to think about for firearms. And the first is the idea of locked storage and decreasing access. And I already said at the outset that the single biggest modifiable risk factor for firearm injuries is access to a firearm at a high-risk time by a high-risk individual. And so one of the key things that we can do across the board is to ensure that firearms are locked in a safe manner. And what do I mean by that? I mean that firearms are stored in a gun safe or locked box, that they're stored unloaded, that they have the safety switch on, that the ammunition is stored separately in a locked box, or they have a trigger lock or a cable lock. And you can see some examples of those things in the pictures here. With a gun safe here, this is a cable lock, and this is a trigger lock that's around a firearm. So what does storage look like among older adults? Well, we know for adults in the United States, between the ages of 50 and 85, that about a quarter of them actually store their firearms in the most risky way possible, which is unlocked and loaded. So available out, easy to be accessed by anybody in the household, by anybody who comes into the household, a child, a teen, somebody who might be experiencing cognitive decline or dementia in the household who doesn't typically own or operate firearms. but about 40% store it in the least risky way possible, which is locked, as I just said, in a cabinet or a gun safe or a trigger lock, and unloaded. And so it's really about addressing that population of people who store it in the most risky way possible, where it can be accessed during high-risk time periods. So who's more likely to keep firearms in that risky way, that loaded and unlocked group? Well, we know that handgun owners who own and tell us they own firearms largely for protection are more likely to store it out, loaded, and unlocked and available. And that increases the risk for somebody gaining access to it. Fortunately, we also know that among older adult populations, they're actually more likely to keep firearms unloaded and locked up when they know they're having children living in or visiting their home, but it's not 100%. And so that's still a population in which we want to address the access to an unsecured firearm. And it's important to consider those off-site sources of firearm access, because we know that homes where children go to play and spend time at their friends, their relatives, their grandparents, that's a large source of accessing firearms. And those firearms can be used in school shooting events, they can be used in teen suicide events, they can be used in unintentional or accidental injuries, and they can also be used in homicides. Less likely in that case, but certainly still a risk factor for firearm access. And so keeping those firearms locked prevents people who shouldn't have the firearm, teens, children, and other people in the household, from gaining access to it. And we know, so when I think about solutions in terms of what can be done in the healthcare space or the clinical space, that families are largely receptive to talking about the issue of firearms during healthcare visits. And as clinicians, we can provide anticipatory guidance or counseling about how firearms can be stored safely. And that when we do that, we do it in a way that's non-judgmental and takes into account the reasons why people own firearms, and do it in a very sort of systematic way, that we can be effective, and that people will change the way they store firearms and make them safer. The other sort of clinical intervention that sort of is paired with locked storage is the idea of access to lethal means at high-risk times. And this is really one of the interventions we think about for high-risk individuals who are at risk for suicide. And so we talked a lot about how older adult populations, the highest risk is really for firearm suicide. So how do we decrease access to lethal means? We know that when suicides occur, that they're largely, the method that's used is largely dependent on what's available and what's able to be accessed at the time. And so that has implications for the outcomes of these events. Firearms are highly lethal. About 90% of the people who attempt a suicide with a firearm are unfortunately successful, whereas with medications, the outcomes are much less lethal. And so if we can not have people attempting firearms or not having people have access to firearms at these high-risk times, we can either decrease the likelihood that they'll try to attempt suicide, or if they do attempt, they might attempt with less lethal means. And we have more time and more availability to get them the help they need to prevent that outcome. So, so I've talked a little bit about the need for both counseling around locking up firearms, and about the need for counseling, especially among high-risk individuals at risk for suicide, to decrease access to lethal means during those high-risk time periods. So how often is that being done currently? And is there room for improvement? And what we see is there's a lot of room for improvement. So about 85% of older adults tell us that they've seen a healthcare provider in the prior year. And over half have received some types of counseling on some type of preventative health issue, but largely it's not around firearm safety. So if you look at the types of things that older adults tell us that they've gotten counseling around, so they're largely, over half are counseled around physical activity and nutrition, hearing issues, oral health, but only about 4% tell us that in the past year, their physician or healthcare provider talked to them about firearms or firearm storage or firearm safety, which again, as an area for improvement, this is a significant area for improvement. But we also know that older adults are receptive to hearing about it. So older adults tell us, over 2/3 tell us that they're accepting of clinicians asking them about firearms in the home and receiving firearm safety counseling. And it's important because 80% of older adults tell us they have no plan for what to do with a firearm should they become unsafe to handle it. So they have no plan for what to do as they get older, as they might develop cognitive decline, as they might be at risk for these self-inflicted injuries. There's no plan for what to do with that firearm. And clinicians are not currently filling that space by counseling and addressing that issue. And so we need to do a better job of addressing that issue. We know that the rates of acceptability are higher among non-firearm owners than firearm owners. It's important to counsel both. And it's important, I think, to emphasize that counseling has to be done in a non-judgmental manner that respects people's decisions about owning firearms, but really tries to focus on the safety. As I said at the outset, people come to this issue with diverse opinions, but if we can focus on the goal of decreasing injury and safety, I think we can really move the needle on some of these outcomes. But I think one of the key reasons physicians and other healthcare providers don't ask about firearms in the home is they don't have the training. We're not doing a very good job of training our healthcare providers about what to do with the answers to those questions, how to counsel people around safer storage, how to counsel them around firearms, because they don't largely know about firearms. They're not necessarily firearm owners, so they may not know about the parts of a firearm or how to store a firearm safely or what to do with the answers to those questions when they ask them, so they don't ask them in the first place. And I think that's an area where we can certainly do better. And our team has developed a series of videos that both talk about educating physicians about firearms and storage and different types of storage, as well as how to provide that counseling in that manner that I said was non-judgmental and respectful of decisions around firearm ownership. And so we're working to try and disseminate those trainings out to healthcare providers so that they can increase their skill set in this area. So I think there's a few other sort of common sense things that as in the clinical space we can do to help try and decrease these firearm injuries. I think it's important when we think about the issue of being non-judgmental and respectful of ownership that we actually screen every patient about firearm ownership, and that we do it in a universal way that it focuses on enhancing safety, because it's not just about counseling their own firearm ownership, but it's about homes where they may go visit or homes where they may spend time where there's access to a firearm. And so it's a universal approach to screening. But I think also then for answers where we get about firearm ownership that are firearms are owned, to then focus on how do we reduce risk and enhance safety in those environments. And so there's a lot of discussion around what's the right way to assess whether somebody, as they get older, has the functional ability to operate firearms. And there isn't a standardized scale right now or screening tool. However, the suggestion has been made to use basically the clinical dementia rating scale, which is an ability to assess for cognitive decline and look at whether or not older adults can do complex tasks like operate a firearm. And we do this a lot around issues pertaining to driving, and I think it pertains also to firearms. And so increasing our use of that to assess whether or not somebody is capable of owning a firearm might be a risk. Then also standardized screening tools for depression and suicidality, and understanding whether there are children who live in or visit the home. Again, trying to figure out who's at higher risk for which types of firearm injuries, and then tailoring our discussion of those preventative strategies to the issues that are specific to that family. It's about increasing and providing locked storage counseling. And it's about recognizing, I think a lot of clinicians, when they start to have these discussions, initially think the only answer is either you can own a gun or you can't own a gun, but it's not bipolar in that way. There's a range of safety options. So there's a range of different storage ways of increasing safe storage and providing locked storage counseling. There's also a range of ways to reduce risk around firearms. So how do we reduce access and availability at high-risk times? So either making it supervised access by a family member so that an older adult who may be experiencing the beginnings of cognitive decline or may have issues around depression or suicidality, but still wants to be able to operate a firearm, maybe they can do it, but only when it's supervised by another family member. Or providing lethal means counseling about temporarily removing the firearm from the home during that high-risk time. There's an issue around smart guns. I'll talk about that in a minute, around how do we engage smart guns so that people don't have inadvertent access to guns that are placing them at risk, and also smart storage options around storing firearms in a way that keeps them safe. There's other ways of making firearms less lethal. So removing the firearm pin, disabling the trigger mechanism, or replacing live ammunition with blanks that can allow somebody to still have a firearm in the home if that's important, but decreasing the potential lethality of the object during that in-between time where it's not time yet to take the firearm totally out of the home, but they may not be totally safe to operate it in the way they were 10 years ago. Temporary removal or storage of firearms off-site. So a lot of gun ranges and shops are increasingly offering the option to store firearms there rather than at home. Or thinking about when is it time to transfer ownership to other family members. And really one approach to thinking about this is, what's the retirement plan for owning a firearm? When is it time to think about changing the way that you own this object, which is lethal in nature and has the potential for injury and harm? It's safe now, but what is it going to look like in 10 years? And what's it going to look like in 15 years? And what's the plan for how to address that or deal with that? As I said, 80% of older adults don't have any plan for that. And what does that plan look like? And it's about clinicians developing a graded, stepped tool for how to address that issue and shift ownership during as older adults may get to stages where they can't operate firearms in a safe manner. So there's a lot of work being done around some engineering solutions. I talked about cars and all of the engineering solutions that have been developed there. And there's a lot of work about developing safer storage options that still allow access for protection, but prevent the firearm from being kept out in the open where somebody may inadvertently get a hold of it. Biometric fingerprint solutions, RFID technology, all these things that are sort of coming down the pike. But there's a lot of work around these solutions to understand what would make them acceptable and be able to be deployed widely to firearm owners. So we know that there are 350 million firearms in circulation currently. And in order for this to be a better and safer option, it has to be acceptable to firearm owners so that they can still use guns in the way they want, but make them safer. And so this is an active area of work that's being done, but I don't think we're quite there yet in terms of the optimal solutions, but potential for coming in the future. So I'll finish up here with this part of the talk by talking a little bit about public policy solutions. And really the public policy approaches to this have really focused around how do we prevent, again, sort of high-risk people from having access to firearms at high-risk times. And they've really focused in a couple of specific areas. So expanding background checks at the time of sale of the firearm. And we know that states that have stricter background checks have lower intimate partner violence risks, lower risk of law enforcement being killed in an encounter with somebody. And we know that when states have weakened their background checks, we've seen an increase in the rates of violent crime that have occurred. So background checks are one tool that are actively being looked at, strengthening in terms of trying to prevent firearm access amongst high-risk people at high-risk times. There's a new tool that's been developed called an extreme risk protection order. It's also called red flag laws a lot in the literature. It sort of builds off of domestic violence restraining orders. Those two policy tools are a little bit different. Domestic violence restraining orders are a broad tool that's really focused around no contact with somebody, counseling, firearm access in the issue of intimate partner violence. Whereas an extreme risk protection order really focuses just on the firearm, but it can be broader than just for risk of intimate partner homicide. It can also be risk for suicide. And so essentially what this is law enforcement can file a petition when they think somebody's a risk to harm themselves or to harm somebody else. And if one of these extreme risk protection orders is granted, then basically the firearms can be temporarily removed from the home during that high-risk time period and given back at the end. The evidence base for these is still being developed. We don't know a lot yet around how they're being used or whether they work or not, but we think it's a potentially powerful policy tool that can be expanded on. Other tools that have been used, focused deterrence has been used a lot around illegal firearm carriage. This is also called hotspot policing. And some of the initial data around this did show that directing policing to areas that have been shown to have hotspots of firearm issues can decrease rates of urban shootings. However, there's been a lot of issues around implementation where these types of hotspot policing have not been applied equally across these hotspots, and they've been differentially implemented, differentially enforced, leading to issues of disparity and equity. And so it's important to acknowledge some of these policy tools when they start to cause unintended consequences. And that's part of the importance of doing research on firearms, is to understand both what works and when it works, but also what are some of the unintended consequences of things when they're implemented in ways that they weren't intended. There's a lot of focus, especially with the Alcohol, Tobacco, Firearm Agency, around how do we prevent illegal firearm diversion. This is more of a problem in the realm of youth firearm violence than it is a problem for firearm injuries among older adults. But we know that a large number of the illegal firearms that are in the market really come from a small number of sellers. And so ATF does a lot of work around trying to address that portion of folks who are responsible for the diversion of firearms to the illegal market and addressing that. And one of the key focuses on that is, foci of that is addressing the gun show loophole. There's some focus or thought around higher standards for legal firearm ownership that hasn't gotten much traction in the policy realm, but I mention it as one area that people are starting to think about and look at for whether there should be some type of standard for when somebody should be allowed to own a firearm. Currently, there is none other than age and the background check criteria. So how do older adults feel about these different types of policies? Largely, they're accepting of these types of policies that enhance firearm safety. So we looked at and asked a national sample of older adults about what their thoughts are about allowing family or police to petition courts to restrict firearm access, similar to an ERPO law or a domestic violence restraining order. They're largely accepting of that, both gun owners and non-gun owners. And then removal of firearms from homes where older adults are beginning to show signs of dementia or confusion, and requiring background checks, increasing background checks, especially for private firearm purchases. And largely all older adults are accepting and of these types of policies, even amongst both gun owners and non-gun owners. So I'll finish up here in the last couple minutes just by saying something about what we're doing here at the University of Michigan. So we have recently developed the Institute for Firearm Injury Prevention, which really focuses on addressing, we have this deficit. I talked at the outset about the lack of sort of attention to the issue of firearm violence as a health issue. And I think that has a lot to do with a lack of research funding that's been available. And you can see here sort of top issues that cause mortality in the United States, and sort of firearm violence falls off the map here, off the standard line of funding, research funding to address the issue. And that's largely been responsible for our lack of progress and our lack of knowledge on addressing firearms as a public health issue. That decreased funding, there's a lot of different ways to measure what the outcomes of that. One is to look at the number of deaths that are occurring and the increase we've seen in the past decade for firearm injuries. The other way in the science community we think about it is the number of research publications that are being published on the topic and the issue. And what we see is that during that funding drought for that length of period of time, there really was a decreased number of scientific publications and a decreased number of researchers focusing on this issue. So if you don't have researchers who can get funded to do work in this area, they leave and they go focus on other important science areas or important public health issues. And the problem is that then nobody's focusing on this problem specifically. But there's been a real shift in federal research funding for this, especially since Newtown. And we've seen a lot of foundations get into this space. We've seen the federal government get into the space, and Michigan's really been successful at garnering some of this funding to really focus on this as a nonpartisan issue, to focus on the science of how we increase safety and decrease deaths from firearm injuries. And because of that, we have started to think about this idea of this institute where we could bring together all these faculty who are working across campus and really have them focus on this problem and stimulate new directions and new collaborations, train new researchers in this space, and really work between academia and community members around how do we solve this problem in a really positive way. And when you think about the model for this, the model really is, again, cars. So I've talked about cars before in this talk, and here you can see every place in the United States that has an academic traffic safety center. And we have one here at the University of Michigan. It's called UMTRI. It's an entire building of people that focus on addressing all the different issues around car safety and preventing motor vehicle crashes. And a large number of academic centers around the country have these types of institutes that bring together multidisciplinary faculty, smart people to get into a room and focus on the problem. And it would be great if in the next 10 years we were able to produce a map that looked like this for firearm injury prevention. And Michigan's really been a leader in sort of addressing that in this way. Just a quick overview, we have different parts of the Institute that focus on research and scholarship, education and training, engaging with communities that are impacted by the problem, improving the data in this space. I talked a little bit about some of the data issues, and then how do we translate some of these solutions into actual policies or interventions or community-based interventions. We focus across all of the issues, including the issues that are pertinent to older adult firearm injury prevention. I talked a little bit about the problem of intimate partner violence and suicide among older adults. And so that's a major focus of the type of work that we do in the Institute. We have a number of, we're organized around these cores with stakeholders having really key input into addressing this problem so that we do it in a way that really is focused on the science and not on the politics of the issue. And I won't go through all of this, but we're focused across the state of Michigan doing work. We're actually focused nationally, but this is a map of all the work we have going on currently in Michigan, including working around suicide prevention, especially with firearm owners up in the Upper Peninsula. We are doing a national survey, the type of survey data that I presented here today, and we're actively working on training new people in this space. And so more to come on all the work that we're doing. But with that, I will stop and take questions.
Okay, thank you so much, Dr. Carter. That was fascinating. And we do have questions. First of all, a basic question. Can you, for the non-gun person, can you define, you talked about large and medium, small caliber. What do you mean by caliber? Please explain.
Oh, yeah, that's a good question. So sort of the type of ammunition that fits into a gun and the caliber of the barrel of the gun. So pistols come in these different calibers. So you can think about 9mm pistol versus like a 22 pistol. So a 22 pistol would be a smaller caliber weapon, whereas a 9mm or a 45 would be a larger caliber. So it's going to have a larger caliber barrel. It's going to require a larger type of bullet that has potential for more impact and more injury.
Mm-hmm. Okay. One question that comes up in the area of protection. People own you said the majority of older adults own a gun for protection, and usually, and this actually, there's a couple of parts to this. First of all, there's the gun owner argument that, well, it's not going to protect me if it's locked up and it doesn't have any ammunition in it. Mm-hmm. So they keep it out, and that's what they say. And so how do you argue?
You address that? Yeah. So I think there's a couple of things. So I think the ultimate solution, I think, to that question is how do we design a safer storage option that allows people to have access to a firearm when they need it, but still keeps it locked up. And so some of these sort of smart storage options that are accessed only by fingerprints or only by a code, but can be sort of the gun can be kept in there, I think is the ultimate solution. Although again, we have to, I sort of talked a little bit about this, you have to make sure that those work at a high rate so that there aren't failure rates, so people feel comfortable with them, and that they're acceptable to firearm owners. So if we don't build them in the way that people are going to buy them and use them, then there's no purpose in building them. So I think that's part of the research work that we have to do. In the meantime, I think it's thinking about, well, are there times that we could store the firearm, or we should store the firearm in a safer manner? So, you know, if you know that you're going to have children in the household, or if you know that you have somebody in the household who is experiencing cognitive decline and is at risk for that firearm if it's left out, how do we make sure that they don't have access to it in those time periods? So I think there's things that we can do sort of in the moment and short term now around counseling about storage. I also think it's addressing this perception of the need to have it immediately accessible for protection when people feel like they live in neighborhoods that are largely safe. So how do we how do we address that fear? That's something at a more community level, but that can be addressed somewhat at the individual level, but I think it's much more of a community question. But that's a larger societal question that is more complex, and I think is going to take some time to figure out and sort out.
Right. It is fear-based behavior. Are there any statistics at all on how often a gun has protected someone who has this in place, this plan in place, and has prevented violence in one's home?
Yeah, so there's not great data on that. There's some controversy over the types of numbers that we see. So so you're talking about is defensive gun use, and those numbers broadly, not just for home purposes, but broadly span, depending on who you sort of read in the literature, anywhere from 300,000 events to like 1 million events per year. But that's not based on solid data, and so I think we need better data on that question specifically. But the data we have probably suggests it's at the lower end, and we do have some data that suggests that in those encounters, the person using the gun in a manner to protect themselves is actually at higher risk for injury than the other person. So there's some suggestion in the literature that that it may not be offering a protective effect in the way people think it is.
Mm-hmm. Yeah, part of this gets also to funding for this kind of research. How hamstrung are you by the politics involved? It's fascinating to me, and I'm sorry I had my mic on when you gave that chart about the firearms deaths surpassing auto deaths, and I went, wow, and I realized I had my mic on. My apologies to that.
No worries. So, you know, I think for years we were, and I sort of showed this slide somewhere in the middle there, you know, for years we were really hamstrung because there wasn't federal research funding to look at this. I think we're starting to see that change. We're also starting to see some foundations get into the space of funding research on this area, but it's really the federal government that funds the most research in the country, and so we are seeing the NIH and the CDC expand their portfolio of research in there. It's nowhere near comparable to the scale and size of the problem. I mean, when you think about among children, firearms are now the leading cause of death. You're more likely to die from a firearm injury before you graduate high school than any other cause. And yet cancer research, which is the third leading cause of death, which is incredibly important and something we should focus on, gets tons more money. So firearms, I'm not saying cancer should get less, but firearms should probably get more. And so we need to really, if we want to move the needle in the same way we move the needle for cars, we need to think about what's the scale of funding that's needed. But in order to roll out that funding, one of the first things you need is you actually need the people to do the work. And so, so I'm seeing the CDC and NIH move more in that direction. I think we as academic institutions also have to increase the number of people that are trained to do the work in this area and focus on the problem and bring all of those smart solutions to the table and develop the new ones that we haven't even thought about yet. And that's where I think the academic institutes like the one that we have at Michigan can really play a role in helping to increase the workforce and the capacity of people to focus on this. And then I think the money has to follow.
Okay. Yeah, I noticed the NHTSA, National Highway Traffic Safety Administration, is up to about $1 billion a year in research funding.
Yeah.
I doubt that you're anywhere close to that.
No, not yet.
Where does your funding for your institute come from?
So there's internal funding that was sort of seed funding to begin it. All of the faculty in the institute also have funding from CDC and NIH to do research in this area. So that's some of it. And then there's opportunities for donorship and, you know, and philanthropy to help fund long-term the institute. And so, and that's obviously a goal of ours, is to help, is to raise additional funds to help support this type of work.
So I worked in engineering years ago, and we would go after research centers, and we would win. When we won a NSF center, we would get, it was on the order of $20 to $30 million. Is your institute
We're not there yet, but we also just started a year ago, so there's
Okay.
still room to grow.
All right. Thank you. Are there, if somebody wants to get rid of a firearm, what do they do? And related to that, maybe the children of someone older want to counsel their parent about this. So talk about that as well.
Yeah, there aren't a lot of options other than either selling the firearm, and there are legal channels to sell firearms, or you can go to the police and turn in a firearm, being aware that the police are, first thing they're going to do is run that firearm and make sure it hasn't been used in a crime, but assuming it's legally owned and legally operated, that shouldn't be an issue. Then, I mentioned a few of the other sort of storage options. You can transfer ownership. If an older adult wants to transfer ownership of the firearm to their son or daughter, that's an option. There are opportunities to store firearms in, gun shops around the state that provide that service. And that's an opportunity to at least get it out of the house in the meantime until we'll sort of figure out a long-term plan for it. But those are kind of the main options available at this point in time.
If you want to transfer it to your son or daughter, is there some paperwork? Isn't it on file with our firearms? They're on file. The ownership's on file somewhere. Is that correct?
Depends on the state. So I'm cognizant we may not be talking to only people in Michigan, but there is the opportunity to get what's called a purchase license. You can go down to the police department, get a purchase license, and transfer ownership from one person to another that way. Mm-hmm. That's the legal way to transfer ownership.
Okay. Oh, one thing to the audience, please put your questions in the Q&A and not in the chat. It's going to be easier for me to organize things. I would appreciate that. Let me see here. Does the NRA contribute to firearm safety research?
I have not seen any specific donations from the NRA for that purpose.
Mm-hmm. Okay.
Although recently the NRA has had some of their own financial issues, obviously. So,
right. Are there some handguns that are safer to own than others?
I think, we talked a little bit about the difference between large caliber and smaller caliber. So in terms of the type of injury that's caused, certainly smaller caliber weapons would be safer from that standpoint. Smart guns, they're in existence, they're not widely marketed on, would be a potential option for a gun that would be safer. But by and large, guns are intended to be fired. So all of them have that purpose. The types of injuries that they can cause range depending on the caliber of the weapon, but they all have the potential to cause injury. So I think the biggest thing is storing them if somebody is going to purchase a firearm and own it, storing them in the safest way, maybe thinking about a smart gun, thinking about a smaller caliber weapon, which may not cause as much injury. Or I think degrees of risk safer, but certainly not. There's nothing that's 100% safe.
Okay. Now here's a public policy question. For public policy, is licensing to own a firearm under consideration, like it's required for driving a car?
Right, and I talked a lot about how the focus of a lot of policy efforts has been around decreasing access among high-risk individuals at high-risk times. There has been some discussion or consideration of should there be a higher standard for ownership? That has largely not gained any traction in terms of public policies that people are willing to consider. But that would be where licensing sort of fits in that realm. Is there some, similar to a car, some standard that people have to pass in order to own a firearm? That has not gained any traction in terms of policies. And we don't know. I mean, there's obviously theory around whether that would work or not to increase safety, but we don't know what the impact of that would be until we sort of try it. So.
Do you happen to know if the police destroy the guns that are turned into them? What happens to those guns?
I don't know the answer specifically to that question. I think it's probably a range of things, but I think a large number of them are destroyed. but I don't know that for certain, so I don't want to say something I don't.
One of the things that seems to be is definitely connected between gun deaths and is mental health issues. I mean, we see this all the time. Often, you know, it's anywhere from what we unfortunately saw in Oxford, Michigan, to violence against women when their partner, they may be separated and maybe there's a restraining order, but that person still has a gun, and they seem, and we too often read in the news that they ignore the order and the death of the female results. Is there anything that's being put in place to address that issue, where mental health or the emotional excitability of the person actually means they have to not only not see the person, but also turn their weapons in?
So 2 points I'd like to just sort of highlight there. So one, I think it's important to acknowledge that, you know, when we talk about mental health, that's a broad category of different types of things. I think some people think about the issues of like schizophrenia and severe mental illness as being a risk factor for firearm violence, but it's actually, it's much more of a risk factor for injury to themselves, not outwardly directed injury towards somebody else. And so I think it's important to not put everybody sort of in that one bucket. And I think it's important to acknowledge that people with more serious mental illness are not at increased risk to harm other people with firearms. They're more likely to harm themselves, which is clearly an issue and something we should address. But I think there's often a perception that that's not the case. But when we think about a lot of these sort of emotional distress, anger management, if we're including sort of that broad swath of issues, then I think, yes, there are programs, and I didn't go into this as much in the talk because I was focusing it more on the issues relevant to older adults, but there are a lot of programs out there that are addressing, especially among youth populations and people who are involved in interpersonal violence, to hospital-based violence interventions, and to decrease sort of some of those factors that we know are contributors to interpersonal violence and homicide risk and intimate partner violence risk. And firearms is a big component of that.
What specific steps could a partner take if they find that their partner they sense they're becoming more and more emotionally unstable? They know they own firearms, plural, and this seems to be a spiral that's not coming out well. What specifically can that person do?
Right. So I think it's largely about decreasing that person's access to the firearm at that high risk time when somebody is starting to experience those kind of symptoms. So, you know, going together to talk to their physician about their ability to own firearms legally, maybe storing it off site, maybe transferring ownership. If those things are not being effective and we're starting to see more higher severity behaviors, then thinking about whether or not that's the time to sort of think about those red flag laws or ERPO laws in the states that they exist. Michigan doesn't have one, but in states where they exist, about sort of filing a petition or going to the police and talking about filing a petition to basically remove the firearm from that situation. I think there are a lot of steps before that and things that people can do by working with their physicians or working with counselors to either decrease access or decrease access temporarily, depending on the nature of the scenario. But basically, it's getting the firearm, you know, not to be accessed by that person if we're seeing increased instability.
So the first thing would be for them to talk to their doctor.
I think talk to the physician about, because they can do that together with the patient. And, you know, if the patient
let's say that might be easier said than done. So they could just go by themselves and talk to their doctor, and
sure, I think they could go by themselves. I think they could talk to other family members, and, you know, it's about maybe bringing family members together to address that issue and whether that person should still own a firearm. But involving the physician into that, because likely there's other things that that person also needs, not just the firearm removal, but there's other services that that person likely needs to address the issues that are going on. So I think it's about sort of both and, not one or the other.
Okay, thank you. Here, this questioner is interested in people who find the person who has committed suicide. Is there any follow-up for their mental health? I don't know if I get well, it must be the person who found the person. Any follow-up for their mental health? Are family members of someone who committed suicide at greater risk themselves?
Well, I mean, I certainly think anytime somebody has a partner or a family member who dies tragically from suicide, that's a very emotionally distressing event. And I think ensuring that that person accesses and gets support that they need in that moment is critical. So I think psychiatry, getting access to mental health resources, suicide crisis line, those are all really important resources, I think, to ensure that somebody has access to address their own mental health and keep themselves safe and healthy.
I think one of your charts showed the increase in suicide among older Americans. The line went up as people grew older. And you equated that to mental health or dementia issues. The elephant in the room is that if somebody is at end of life or has had a bad diagnosis, they don't live in a state where you're allowed to pass peacefully, that they may take that option. Could you discuss that a little bit?
Well, so I think it's broader than just the issue of dementia. I'll say that older adult suicide, I think also it occurs amongst a large population of people that don't necessarily have cognitive decline or dementia issues. They may be experiencing depression from, as you sort of are alluding to, prolonged illness or social isolation or high rates of alcohol drug use. All of those other factors are potentially contributing factors to the problem of older adult suicide, not just dementia. I just want to sort of add that at the outset. I think the issue of older adult assisted suicide, especially around terminal medical issues, is one that's, as you said, still controversial, and one that I think is still something we're sorting through as a society. But I think at least making sure that people don't have access to firearms in those moments, because I think we can do a lot to support people, is probably the goal I would highlight there, to decrease those outcomes, because I think it's not all, those numbers are high enough that it's not all about people with terminal diagnoses. It's largely about people who don't have that. It's largely about people who are experiencing depression or experiencing social isolation, family discord, and then the problem of confusion and cognitive decline, as I talked about. So I think there's a lot we can do to address the majority of the people before we get to the issues of sort of older adult assisted suicide.
Okay, thank you. Here's a question about the number of guns. It seems like, I forget what the number is. In the U.S., we own like an order of magnitude more guns than anybody else in the Western world, like 10 to 1 or something. What is that number?
I don't know the exact number off the top of my head, but your estimate sounds about right. Yeah.
Yeah, and so the question is, how do you feel about the capability of making guns with 3D printers or ghost guns with no serial numbers, unregistered guns, and the accessibility on the internet to look up how to build a gun with 3D printer how does that impact your research? I mean,
well, I think
got this flood coming at you.
Yeah, I mean, the majority of guns are not produced either yet through ghost guns or 3D printers.
Yeah.
But I think about that kind of in the same way as I think about guns, that is not a legal channel to obtain a firearm. So those fall into the bucket of sort of illegal types of firearms. And, you know, how do we prevent people from gaining access to illegal firearms that they shouldn't have access to? And so because largely those guns are being used in interpersonal violence issues. And so, you know, how do we decrease those behaviors? How do we decrease access to guns among higher risk individuals who shouldn't have them for that period of time?
Okay. Oh, I do want to mention there's a question here, and I think I was going to address it at the end, and I will, but this presentation will be available for viewing in about a week with all of Dr. Carter's slides included. So somebody wondered about that, and I wanted to let them know that they would be able to view it and show their partner if they chose. Is there a similar amount of research going on about other weapons? You know, for example, knives.
Yeah, I think so. There is other research going on about weapons broadly. When we think about the lethality of different types of weapons, and we think about the ones that are being used most commonly, you know, guns are much more likely to be used in especially in interpersonal violence issues than knives are, and they're just much more ubiquitous. And so I think that's partly the focus on them. But knives are out there, and knives cause injury too. They just don't tend to cause as fatal injuries as firearms do. So they're less lethal in nature.
Okay, thank you. So at the beginning of your talk, you showed one of your charts was, again, it was the firearms death that surpassed auto deaths in 2017. So with that curve going up, what were the primary causes? Was it suicide? Was it homicide? What were the primary causes?
So both suicide and homicide have increased since 2017. The data from the past year actually shows homicide rates have gone up higher than suicide. But in general, if we go back and look at sort of the increase from the start of 2013, 2014, we're seeing increases in both firearm homicide and firearm suicide.
Okay, thank you. Okay. I think we've gotten everything that I've got. And you did see a lightening up of the political resistance to funding this research.
Yeah, I think after the school shooting in Newtown, there was a shift in funding, and we've seen that grow as people realize we can do this research in a way that is focused again on the data and the science and not on the politics. And I think as we've shown that we can do that and really address some of these really you know, what I would call low-hanging fruit, things that we can really move the needle on, and that's where the focus is. People are seeing that research can be done, and more of the funding is coming, but there's still a lot to do. So.
Yeah, one of the things that we found successful in our engineering research centers was collaboration with industry. We have industry partners. Have you looked at that with your institute?
So we're just getting into that space a little bit now. I agree with you that, you know, thinking about these issues around, you know, as I talked about, how do we build a safer gun lock or a safer firearm that is acceptable to gun owners and can be used? I think that's an engineering question that could be a partnership there. How do we think about, you know, thinking about firearm safety in sort of the workplace and among workers, I think is another issue that we've thought about. So how do we build partnerships with corporations to help do those things? And so that's an area we're getting into. It's not an area we have had a lot of work in so far.
Okay. Okay, I think that's all our questions. Jen Howard, I actually would like to invite you to come on and explain to people how they're going to have access to this lecture, because it's so important.
Yeah, hi everyone. In about a week, we will send a recording link that will go out to everyone who registered for this, along with Dr. Carter's slides. And we have actually now created a link that should be sent out later today to all of you and anybody who's registered for any of our health series lectures. And that link will get you to a YouTube channel that will have every single lecture that has been recorded for the Healthy Aging series, including this one. So you can bookmark that link, and then as the series progresses through the end of May, anytime you want to catch up on one of our lectures, you can just go back to that bookmark, to that link, and they should all be right there for you on YouTube. And it should be really simple. And if anybody has any questions in the meantime, or would like more resources from Dr. Carter, any more questions, please give us a call here at the Turner Senior Resource Center at 734-998-9353, and I will put that in the chat for everybody.
Okay. Well, thank you. That number 734-998-9353. And thank you, Dr. Carter. This is a very, very worthwhile lecture. We really appreciate your time today. Thank you so much.
Thank you for the invitation. Thank you for focusing on
our
this
audience.
issue.
Thank you, Dr. Carter.
Okay. Thank you, everybody. Have a good day.